Over to you.
Good afternoon, doctors. Welcome to this program on experience sharing program on managing PPH, case studies from labor room. This program is brought to you by Hetero Healthcare. Hetero Healthcare, as you know, we have got 25 years of excellence and 36 state-of-art manufacturing facilities. We have 300 plus products in our portfolio and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation. We have distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's program, Experientiation Program, we have got Honorable Speaker, Dr. Rizwana Afreen. Welcome, Madam, to this program. Dr. Rizwana Afreen, Madam, is
Thank you.
MBBS MS with 17 years of professional experience and currently consulting obstetrician and gynecologist, Lifeline Hospital, Yadgir, District Surgeon, District Hospital, Yadgir, with special interest in fertility treatment. Over to you, Madam, and I will run the slides.
Yeah. I thank the Hetero Healthcare for giving me this opportunity to speak on one topic that postpartum hemorrhage. Of course, as postpartum hemorrhage event as well, a nightmare for an obstetrician happens because everybody has a positive anticipation whenever a delivery happens, whether it could be a vaginal delivery or it could be a cesarean section. Nobody expects a death or nobody expects a complication out of any normal delivery. So in such scenario, we encountering postpartum hemorrhage on a day, which is a nightmare for us. And to prevent that second, it's a for an obstacle because decision to be taken in seconds and then go with the events followed and then preventing the death. But of course, when we prevent a death out of postpartum hemorrhage, it will be a satisfactory feeling for all of the obstetricians, as all of you all know. So as all of us that post-delivery, there is 500 ml of blood loss in a vaginal delivery and 1000 ml blood loss, which is a normal blood loss in a cesarean section. Now, when you see this, the slide shown on the presentation now, you can see a contracted uterus post-delivery and a flabby uterus, which is just like a pillow post-delivery in the second figure. What you show? What is seen to all of you all? So PPH is common and can occur in women who are not at risk. Even not at risk, PPH can happen. It is the leading cause of maternal mortality in low-income countries and the primary cause of nearly 35% of mortalities do occur because of PPH. Postpartum hemorrhage, it's an unfortunate yet common. It is a leading cause of maternal mortality, accounting for about 35% of maternal deaths. And MMR is in developing countries is 240 per 1 lakh live births compared to 16 in developed countries. So the global 14 million women suffer from PPH. Incidence is as 2 to 4% after vaginal delivery and 6% after cesarean section. Yes. Am I audible to all of you all? Is my voice clear to all of you all?
Yes, Madam.
Yes, madam.
Yes.
Now it is.
Yeah. Okay. Thank you. 38% of deaths are due to PPH. Out of that, 25%, 25.7% of global deaths take place in India, and 2/3 of these attribute to PPH. India has an unexpected high mortality rate of 540 per 1 lakh live births, which is again an area of concern, which we all obstetricians need to emphasize our knowledge and reorient with programs like on PPH management in our district hospitals as well as in our private hospitals. What is etiology of postpartum hemorrhage? It is the toe of the uterus matters a lot. By nature, uterus has to contract post-delivery, post-extraction of the placenta, post-delivery. So as all of us all know, that it is uterus to contract, which may lead to continuous bleeding, which may lead to the death of the patient in seconds, in minutes, in hours. And of course, coagulopathies, failure in clotting, and then traumatic PPH, wherein injury to the birth canal, rupture of the uterus, uterine inversions, and lacerations. As well, the last but most important, most of the times it's been neglected when it is when the delivery is conducted by the staff nurses. It may be because of the retention of placenta or clots and abnormal placenta. So, what are the clinical findings in PPH? Of course, it's a subjective finding for a doctor to know whether the PPH is happening. As we say, that is 500 ml of blood loss in a normal delivery and 1000 ml in a cesarean section. Anything more than 500,000 ml is again a case for PPH. But then, what are the indications actually to say whether there is a PPH or not? We can of course see there that in cesarean section, post cesarean section, there may be abdominal tenderness, or there may be circulatory collapse, increased abdominal girth, loss of uterine contractions, maternal tachycardia, vaginal bleeding. Now, when we say this is just not that important. Of course, the clinical scenario actually happens when we concentrate more on the vitals. Vitals is the patient history with the vitals. Of course, we all of us, when PPH happens, we are all test, we forget to see the vitals, and definitely we lose the patient in seconds. So, my urge or my request to all the obstetricians, whenever PPH is happening, definitely need to declare to the entire labor staff as well as OT staff as well as to the attendants that there is an emergency and we need to immediately act. Call for help is a go-to message from this presentation. So when we see the vitals, definitely when we catch up the patient in a compensatory phase and mild degree of shock, definitely we can save the patient and we can prevent irreversible shock happening to the patient. So when there is a blood loss, 10 to 15% of the blood loss, there is no change in the blood pressure, there is no change in the vitals. Patient has just palpitations, dizziness, and tachycardia. When it comes to mild PPH, that is 1000 to 1500 ml, that is 15 to 25% of the blood loss, definitely there is a slight fall in the blood pressure, maybe around 80 to 100 mmHg, wherein the patient will complain of weakness. You can see the sweating, you can see the tachycardia. And then when there is 1500 to 2000 ml of blood loss, that is 25 to 35% of the blood loss, that is moderate amount of blood loss, there is market fall of blood pressure, that is 270 to 80. Definitely there is restlessness, pallor, oliguria. And when there is a severe blood loss, say around 2000 to 3000 ml of blood loss, 35 to 45% of blood loss, there is a profound fall in BP and there is a collapse of the patient. There is air hunger, there is anuria. So when we see that there is PPH which is happening, what I see first of all is the first sign which comes to my mind is tachycardia. Whenever I see a tachycardia and there is a minimal extra blood loss from what we say around 5 to 1000 ml, you can see the first sign is tachycardia. Immediately catheterize the patient, start resuscitating the patient, take the grave risk consent, arrange from the blood loss, and do all the necessities which is required to resuscitate the patient before patient lands into moderate or severe PPH. So we should train our labor room staff so sufficiently that the patient doesn't go into moderate and severe PPH. That is my go to home message from this presentation. And now coming to how do we diagnose postpartum hemorrhage? That was the clinical findings now. Now, what is the initial evaluation? That is rapid assessment of patient status, presence of tachycardia, heparin, assessment of vital signs and blood loss, and examination of at the time of hemorrhage, assessment of the entire genital tract, examination of the assessment of the entire genital tract for lacerations, hematoma, signs of uterine rupture, manual examination for retained placental tissues, assessment with bedside ultrasound to check if the uterus is non-contracted, evaluation of uterus to check for uterine inversion, and of course the laboratory parameters wherein we are going ahead with complete blood counts to check hemoglobin, hematocrit, and platelets, coagulation studies, and assessment of fibrinogen. So whenever we do this, take the grave risk consent, then go for take a help from your the nursing superintendent of the hospital, as well as call out for a help from the anesthetist, as well as take the assistance of a neighboring obstetrician, and then go ahead with whether it is a tonic PPH or whether it is a traumatic PPH. Of course, the treating obstetrician will be in trauma, will be in stress. So, taking assistance from the people around is not going to let us down. So, let us work for the patient and then assess what stage of shock the patient is in, and accordingly, let us work on that. And now, what is the approach towards the postpartum hemorrhage? Clinical findings, of course, I said the abdominal palpation. Whenever we see vitals, after vitals, we are going to assess the overall consciousness of the patient. Whether the patient is conscious oriented, whether the patient is lethargic, whether the patient is lazy, or whether the patient has sweating, palpitations. Go for the start from the basics. Basics, vitals, followed by the general examination of the patient. Then go for the local examination, that is, go for abdominal palpation. You can very well see that the uterus is completely like a bag, or it is completely like a pillow, feeling very much relaxed, bogey, and soft. Uterine fundus may be felt above the umbilicus if uterine cavity is filled with blood and clots. And in such scenarios, again, we are going to, again, whatever investigations, the blood, the coagulation profile, urea, and electrolytes to be sent. Patient is not responsive to fluid and replacement. They then go for abdominal ultrasound to exclude uterine rupture or intraperitoneal bleeding. Then how do we manage? Of course, management is again a very important thing. Go ahead with the uterotonic agents. Go for the medical line of management. Secure 2 IV lines. Start with IV fluids. Go for oxytocin. Go for prostaglandins. Go for alkaloids. And um, then go for uterine balloon tamponade. As we all know that whenever there is an atony of the uterus, first we are going ahead with the uterotonics, which is a very important role in management of PPH. Only when the PPH is not managed by the uterotonics, which has to happen, the decision has to happen within the 10 minutes, or say it within 5 minutes. If the uterus is not contracting within the said limit, then go ahead with the second maneuver, that is uterine balloon tamponade, or manual compression of the uterus, or Beckery balloon, or we can take the patient to the OR. That how we manage PPH regularly at our hospitals. And then if there is a traumatic PPH, say if there is hematoma or there is bleeding from the areas of trauma, either it could be in the OT, or it could be from the genital tract during the vaginal delivery, or it could be a case of uterine rupture, or it could be an extension of uterine angles, or there could be tears during the cesarean section, or there could be subcapsular liver rupture or rupture of ovarian or splenic vessels, which usually happens when we are going ahead with the fundal, when our sisters are going ahead with the fundal pressures, or even the fundal pressure during the cesarean section. There is a chance of rupturing the liver or rupturing the ovarian or splenic vessels. That we need to see all these clinical findings. Accordingly, send the investigations. Inspection during the cesarean section, of course, to see the extension of uterine angles, to see whether we have gone whether the tear has extended into the parametrium. You can externalize the uterus and then go for the ultrasound of the patient. Then how do we manage? Management is again repair of the identified genital tract trauma. What I find is whenever there is a genital tract trauma, see whether when there is a cervical tear, the bleeding is so massive, and we doctors definitely we get so much tensed, and we are so much stressed before the patient. We hesitate to see this trauma, and we are uh, so much stressed that that is the reason I'm talking always about taking an assistance from the neighboring doctor and also from the sisters, and we maintain our cool. Maintaining our cool is most important area. Only then we can genuinely and we can coolly analyze where the tear has happened, and by then we can our decision making will be very easier. We can treat patient immediately and note exactly whether it is traumatic or whether it's atonic. And now that is now pelvic embolization. It happens in tertiary care centers. We can also may be required in cases of broad ligament or supralevator hematomas. Hematomas are again a nightmare in our hospital, wherein we go for the episiotomy suturing. Our sisters suture the episiotomy, and neglected patients, if we don't um, check the vitals post delivery every 15 minutes, then we are likely to neglect or ignore the hematomas which happens following deliveries. So retained tissues, retained placentine membranes, which is identified again during bimanual examination, then we have to examine such things under anesthesia. Then again, manual removal of placenta or retained products of conception under regional or general anesthesia. When there is a coagulopathy, one of the reason for PPH, again coagulopathy disorders, when there is when the uterus is contracted and you see that there is no trauma, but the patient is still bleeding, definitely we are suspecting coagulopathy is there. There, wherein we are going to send the urea electrolytes, we are going to send full blood counts and the coagulation profile. And then how do we manage? We have to manage these cases immediately with the replacement of blood and coagulation factors and platelets, which is again very, very important. As we all of us know that we are going to transfuse the blood along with the blood products. 1:1 ratio. So in cases of coagulopathy, this is definitely going to help out the patient. And of course, surgical only with trauma or atonic hemorrhage unresponsive to medical treatment. If the treatment is not helpful in case of atonic PPH or it could be coagulopathies, definitely take the patient to the OT, rush to the OT, then go ahead with internal iliac artery ligation or go ahead with uterine artery ligation or go ahead with peripartal hysterectomy. Now, the most important criteria, the very goal of taking up this presentation is carbetocin. How exactly carbetocin helped me in treating the patient in my hospital, saving around patients in cases of PPH. When recognized in early stage, when the patient was in a compromised state, when the patient was in minor degree of stage of PPH, or whether it was a case stage of moderate to severe PPH, carbetocin really helped. What is the rationale for the development of carbetocin in a new heat stable formula? It's a new heat stable formulation to repeat. So carbetocin is available in a room temperature, stable formulation, and convenient vial representation. So oxytocin and ergot alkaloid should be kept in a refrigerator to avoid degradation, as all of us know. And heat stable formulation of oxytocin is currently not available, as all of us know again. And previous formulation of carbetocin should be stored between 2 degrees centigrade and 8 degrees centigrade. Resource poor countries do not always have a cold chain transport and storage capabilities. So carbetocin is stable at room temperature, has shelf life of 24 months at 30 degrees centigrade and 75% humidity, avoids need for cold chain storage and logistics. It's very, very, very important, and it is provided in a void. Because we see that most of the staff nurses, whoever are there in the hospital, provided we have a cold storage in our hospital or in the periphery when there is cold storage availability is not available, then carbetocin, which is a new heat stable formulation, really helps in this case scenario also. What so what is the administration of tonic agents? Of course, all of us are absolutely whether it is at the crowning of baby's head or at the anterior at the delivery of anterior shoulder, at the end of second stage of labor, following the delivery of placenta. It can be a prophylactic use. Most of the times, I use for prophylactic usage only before the patient go ahead with PPH, because PPH is a nightmare which can happen even in the cases where we are not anticipating PPH. PPH can happen. So I use uterotonics as prophylactic in my hospital. So, uh, or it could be active management of third stage of labor. Therapeutic use, management of PPH. So molecules which are used as uterotonic agents is, of course, oxytocin, carbetocin, ergometrin, symptometrin, and misoprostol. Now, carbetocin. The new molecule, the purpose for what we are speaking about is carbetocin. It's a next generation drug for PPH management. So, carbetocin was created by making several modifications to the oxytocin structure. You can see the modifications there, which is presented here in the PPT. So, carbetocin prolongs half life, reduces enzymatic degradation. Synthetic long acting analog of oxytocin. So, carbetocin, it's an analog of oxytocin, making modifications to the oxytocin structure. Therapeutic indication for this prevention of postpartum hemorrhage due to the uterine atony and physiology and administration. That is, one vial will contain 100 micrograms of carbetocin in 1 ml solution for injection. That is, it's a 1 ml vial. It has 100 micrograms of carbetocin. So again to repeat, carbetocin is an analog of oxytocin and used in the prevention of postpartum hemorrhage due to uterine atony, and it is a 1 ml vial which has 100 micrograms of carbetocin. Now, if you see the clinical scenario, brief description, that is synthetic cyclic peptide form of the natural occurring posterior pituitary hormone binds to oxytocin receptors in the uterine myometrium, stimulating contraction of these uterine smooth muscles by increasing the sodium permeability of uterine myofibrils. Pharmacokinetics, intravenous injections, almost immediate action with peak concentration after 30 minutes. Intramuscular, slower onset of action taking 3 to 7 minutes, but produces a long lasting clinical effect of up to 60 minutes. Half life is 1 to 6 minutes. Requires protection from light and storage of 2 to 8 degrees centigrade continuously to preserve its activity. Clinical indications, oxytocin is again induction of labor, augmentation of labor, prevention of PPH, treatment of PPH. Heat stable carbetocin is long acting synthetic analog of oxytocin with agonist properties, binds to oxytocin receptors in the uterine smooth muscles, resulting in rhythmic contractions, increased frequency of existing contractions, and increased uterine tone. Sustained uterine contractions within 2 minutes. That exactly. Now we see that the slower onset of action, we are seeing the action of oxytocin within 30 minutes, but the carbetocin is acting within 2 minutes, lasting for about 6 minutes, and followed by rhythmic contractions for 60 minutes, which is very quite helpful. And IM sustained uterine contractions lasting for about 11 minutes and rhythmic contractions for about 120 minutes. Half life is 40 minutes. Again, half life is also 40 minutes, and storage is up to 30 degrees centigrade, which is again a positive finding with carbetocin. And it is heat stable carbetocin. Of course, used only for the prevention of PPH, not for the induction of labor, nor for augmentation of labor. Just PPH, which is happening because of atony, carbetocin is used. So when you compare oxytocin with carbetocin, of course, carbetocin analog of oxytocin, but then the action, initiation of action is within 2 minutes, and you're getting a sustained uterine contractions, which will be lasting for 60 minutes. So definitely there is a longer hand of carbetocin over oxytocin. Carbetocin is not inferior to oxytocin. Study design, if you said non-inferiorly double-blind randomized trial which was conducted to compare the effectiveness and safety of investigational heat-stable carbetocin to oxytocin in the prevention of PPH after vaginal birth. Patients enrolled were 30,000 women across 10 countries. What was the outcome of this study? Which a trial which was conducted by the WHO, Department of Reproductive Health and Research. What was the primary outcome after the patients, after the study were 30,000 women? The proportion of women with blood loss of at least 500 ml or the use of additional uterotonic agents. The proportion of women with blood loss of at least 1000 ml. So parameters when there is a blood loss of more than 500 ml or the use of additional neurotonic agents, the efficacy of carbetocin is 14.5%. And when compared to the oxytocin, which the efficacy is just 14.4%. And blood loss of more than 1000 ml, the efficacy of carbetocin is 1.51%, and the efficacy of oxytocin is 1.445%. And the safety is 4.9% with carbetocin and 4.7% with oxytocin. So, the frequency of expected adverse effects did not differ significantly between the two groups. If you see the adverse effects, there was significantly no much difference between oxytocin and carbetocin. So, the frequency of blood loss of at least 500 ml or the use of additional neurotonic agents with carbetocin was proved to be non inferior versus oxytocin. This is a marking headline for the go to home message after we present this. Frequency of blood loss of at least 500 ml or the use of additional neurotonic agents with carbetocin was proven to be non-inferior versus oxytocin. The use of additional neurotonic agents intervention to stop bleeding and adverse effects did not differ significantly between the two groups. So carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional neurotonic agents. Conclusion to conclude with. So, what is the Cochrane review over carbetocin for prevention of postmortem hemorrhage? In this Cochrane review data, which was conducted from 11 studies involving 2,635 women, were included here. So, the author concluded that for women who undergo a cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer adverse effects. So definitely there is very much little difference between the adverse effects following carbetocin and oxytocin. But the advantage of carbetocin has a upper hand over oxytocin. So this Cochrane review showed the concluded this study with the report what I just now mentioned to all of you all. Guidelines recommended recognize the benefits preventing uterine tone. Society of Obstetricians and Gynecology of Canada, Danish Society of Obstetrics and Gynecology. So recommendation bodies, guidelines for patient prophylaxis. What is the WHO recommendations in the year 2018? Only for the following: oxytocin. It was recommended by WHO. Carbetocin as one of the uterine tonic for PPH prophylaxis, and also SOGC Canada 2009 carbetocin 100 micrograms IV bolus, and Ranzog COG New Zealand active management of third stage of labor prophylactic uterotonics. It was recommended. Figo carbetocin, one of the recommendation for PPH management. Germany also recommended. Germany, Austria, Swiss body carbetocin 100 micrograms slowly IV. FCOG France carbetocin on proving non-inferiority over oxytocin. So these were the recommendations by the various organizations as carbetocin as one of the uterotonics for prevention of PPH.
Thank you very much, madam.
Thank you so much.
Madam,
Thank you.
yes.
Thank you for your cooperation.
Madam, since how long you have been using carbetocin?
I've been using carbetocin for the past 1 year, sir.
Okay. And which is the route you commonly use?
I use it in cesarean section. I use it IV because in
IV.
cesarean section my anesthetist will administer it IV, and in
Right.
vaginal deliveries I administer it IM.
Right. And how is your experience overall?
Definitely. So far till now, my patients have never gone into the third stage of shock,
Very
and
nice.
carbetocin has effectively. I was able to manage the PPH. in so many case scenarios. In
And
the
as you
cases
rightly,
where I anticipated PPH, I kept ready with the carbetocin on table and started off the procedure. So it really helped me with
correct.
prevention of PPH in my hospital.
There is a few questions. In which patients we can, of course, as you rightly said, we can expect PPH in any patient at any time. But generally, in which patient do we anticipate PPH?
PPH is anticipated as we all of us know that anemia is the primary cause in my area, a place like Yadgir, wherein
Okay.
we come across the patients who are lower middle class or poverty poor patients, wherein their
Yes.
nutritional anemia is there. So anemia forms the major indicator for PPH in our Yadgir population. Secondly, it is multigravida, gravida, Gravida 4, Gravida 5, Gravida 3, they're almost malnourished, and definitely we'll see the PPH there. And what we see in our district hospital, as well as in our Lifeline hospital, when we see that patient being referred after a prolonged labor in periphery. So these
Okay.
prolonged labors, definitely uterus is exhausted and that may bleed. So we see the tonic PPHs in such patients.
Also, patients with fibroids, patients with diabetes are generally more, what I say,
Yeah,
prone to
yeah,
get
definitely. The
PPH. Yes.
comorbidities associated
Yes,
patients
yes.
like PIH patients,
PIH, yes,
severe.
PIH.
Already we have started with them with the magnesium sulfate, which is again a uterine tocolytic.
Relaxant,
Definitely,
yeah,
we are
yeah, yeah.
anticipating PPH there. Yeah,
Correct.
such cases, as well as patients with bleeding disorders, with cardiac diseases, especially
Oh, yeah, aspirin.
undiagnosed cardiac cases. Definitely we are
So there,
encountering PPH. So
yes, yes.
there is a long list. If I go
Yeah,
on
yeah.
speaking, it will take another half an hour to speak over that.
And
Yes.
and of course, I mean, as you rightly said, you expect the unexpected in any patient. That's the golden rule
Yeah,
these
yeah,
days.
definitely.
Yeah.
Yeah, yeah.
Can we use
And in our
carbet?
area, one more thing is this prolonged PV leaks. Prolonged
Ah,
PV leaks. In
yes,
our
yes.
area, I mean, patient leak and they don't come to the doctor immediately.
Oh,
So such
oh,
cases
oh,
are going for choriamnitis, and
absolutely,
we encounter
absolutely,
PPH
absolutely.
in such patients. Yeah.
Correct. Can we use carbetocin in case of a retained placenta?
Retained placenta, see again, yeah, definitely the uterine atony, because of the retained placenta, uterus will not be contracted. So, definitely carbetocin can be helpful in case of retained placenta.
Placenta.
Wha-
Uh,
After finding out,
yeah. And in case of RH negative mothers,
yeah, definitely
yeah. So this
we
could be
can
a
go ahead.
major problem. Yeah, yeah. Oh, can we use a
See,
carbetocin for
RH negative has nothing to do with administering carbetocin.
okay. And can your doctor use carbetocin for prevention of PPH if oxytocin was used for induction?
Yeah, definitely. Definitely we can go ahead with carbetocin.
I mean, the receptors
If
being same,
oxytocin is used for labor induction, we can go ahead
yes,
with carbetocin.
carbetocin. And oxytocin half-life is also short, so it
Yeah.
may not, yes.
Yes,
In
sir.
which, I mean, you have answered already this question. I want you have
Yeah.
said you prefer IV in cesarean section, otherwise IM.
This is again goes with the experience of the doctor, sir.
Yes, yes,
I will
yes.
be using IV for cesarean section, IV for vaginal delivery. So again, it goes with the experience of the doctor with
Very
the
correct, very
patients how
correct,
they handle.
very correct. And availability, at every places there may not be availability for which vaginal deliveries in the interiors. So, I mean, people may prefer intramuscular route.
Yes, yes.
Yeah. Is there any side effect of carbetocin? Severe side effect of
So far in my
carbetocin?
hospital, I have never seen any side effects in
Very good.
relation to carbetocin, sir.
Very good, very good, very good. Even because
Yes.
PPH itself is a condition which is extremely good to discuss, but one should never get a patient of PPH. I mean, and to add to the side effect
Yeah.
of drugs, yeah. Madam, have you
Actually,
seen?
sir, this carbetocin, oxytocin, they're all wonder drugs when it comes to
Yes,
uterine
correct,
atony.
correct, correct,
So
correct, correct,
definitely we don't expect any side effects when in relation to these uterotonics.
correct. And madam, have you experienced any ADH related side effects with oxytocin anytime?
Side effects with oxytocin, sir, so far in my clinical practice, oxytocin, of course, when we use it for augmentation of labor, definitely we have seen that there is an entity called uterine tachysystole. when it
Yes,
comes to
yes, yes.
augmentation of labor. But when it comes to PPH, sometimes patient don't respond to the amount of oxytocin we give. If we
Acha.
exceed the limited amount of oxytocin, definitely there is going to happen. There are so many complications
Yes,
associated with
yes,
that.
yes, 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 yes.
Yes, sir.
And if a patient is not responding adequately with carbetocin, then what next? I mean, your
Of course, sir.
additional
Again,
oh,
if the patient is not responding to utrotonics, then definitely we
everything,
are going for
everything.
laparotomy, or we are going for manuals.
And I
We are
mean,
going for
the
balloon tamponade, we are going
yeah.
for Beckery balloon, we are going for manual compression, then take the patient for laparotomy, go for again, it is again a discussion to
Yeah,
be
I
discussed.
mean, the only answer will be everything available.
Yes, yes, definitely, sir.
Yes. And what are the advantage of carbetocin over other uterogenics? Of course, no storage requirement, I mean, cold chain requirement or single dose itself is an advantage. Besides that, adverse effect related side advantage.
Of course, again, then the carbon is easier to use, not require, as you said, it doesn't require a storage.
Yeah, yeah, yeah.
Again, this itself is the biggest advantage, sir. What
Correct,
according to
correct,
me
correct.
is, it is definitely, and then oxytocin we are giving 20 units, 30 units. Here, carbitocin we are just making 1 ampule, which is easy
Yes,
manhandling, right?
exactly, exactly. Yeah.
And
And you don't need to
the immediate onset of action also is again another advantage
advantage.
of carbetocin.
Right, right.
Yes.
I mean, should it be kept as a reserve drug or should be used as a first line?
For me, it should be used as a first line.
Absolutely, because I mean, the condition is such, that life is at stake. You have to use whatever is available at
Yeah,
the first line
life is at
phase.
stake.
Yeah.
And when the uterus is pumping around 80% of your blood
Okay.
during the
Correct.
time
Correct.
of labor, there is no second
No.
question
No.
or
No.
answer to be answered. It has to be
Correct.
kept as a first line.
What is the role of an anesthetist vis-a-vis gynecologist in choosing the drug? I mean, you have said that you're an anesthetist and you decide finally for cesarean anesthetist gives the injection. But does the anesthetist influence about use of uterotonics? Or is that gynecologist decision?
Sir, definitely. See, whenever when the patient lands up, okay, first stage and second stage of shock, the gynecologist herself is dealing with the case. But when the
Correct.
patient becomes unconscious and when there is oliguria, and there is remarkable fall in the BP, definitely the anesthetist role starts there.
Hmm.
So we need to give the call to the anesthetist when there is a minimal blood loss itself, so
Correct.
that
Correct.
when the patient goes into third stage of shock, definitely we need intervention from the anesthetist. But
Correct.
when you're talking about uterotonics, what is the role of anesthetist in uterotonics? Definitely, as I said, in OT my anesthetist only will administer the carbetocin IV.
Correct. Correct.
Yeah,
Because in cesarean,
but
then
they
you
have,
will, yeah.
yeah, yes, sir.
Yeah. No, no, in cesarean, when the obstetrician is performing the operation. I mean, the anesthetist
Yeah,
will have to, yeah, yeah.
yeah, definitely, sir.
And to conclude, madam, take home message, your take home message to the audience.
My take home message to the audience here is that definitely PPH is a nightmare for all of us, as all of
Yeah,
us know. And PPH is a preventable cause of maternal death. If we see the case scenario, just now I spoke the statistics, but to be frank, PPH, third stage of PPH, management of PPH, and having said so much about carbetocin, I need to I need all the audience take it as a take home message. Carbetocin should be the first line of management in your hospital because it is analog of oxytocin and it is much effective than oxytocin. What I say, so just keep this drug as first line of drug in our hospitals.
right, madam. Thank you
Okay,
so
sir.
much, madam. Thank you so much for
Thank
sharing
you,
your
sir. Thank you
experience.
so much.
Thank you. Thank
Thank
you.
you, sir. Thank you.
Yeah,
Thank
I'm
you.
sure the audience must have benefited out of your experience because this experience is which gives them confidence about using a drug more than the references. Thanks. Thank you
Thank you.
very much. And
Thank
thanks
you so much.
all, yes, thanks all the doctor who took time from their busy schedule and attended this webinar in the afternoon. Thank you, marketing team, thank you, sales team, and thank you, IT team for coordination. Thanks, Bivas, thanks, Naga Devi, and thanks all. Madam, you can sign out. Wish you a very pleasant
Thank you so
afternoon.
much. Thank you,
Thank you so
everybody.
much.
Thank you, Metro
Thank
Healthcare,
you.
for giving me this
Thank you.
opportunity to talk. Thank you so
Thank
much.
you. Thank you.